Welcome to this learning module on the most exciting and long-awaited therapies to hit the emergency medical services arena since video laryngoscopy and the career-saving addition of the auto-load power stretcher. Non-invasive ventilation with the Hamilton T1 is more than just a tool, it's a game changer. Its revolutionary impact on our ability to provide life-saving care should inspire and motivate us as healthcare professionals. Is your patient hypoxemic in the throes of acute pulmonary edema? Thanks to the T1, CPAP or BiPAP, and up to 100% oxygen is at your fingertips. Is your patient an exhausted, air-hungry asthmatic or retaining carbon dioxide suffering from COPD? Let them suffer no more. Intervene swiftly with medical management and avert intubation by promptly initiating BiPAP. Setting up CPAP and BiPAP with the T1 is seamless because mechanical ventilation, CPAP, and BiPAP all utilize the same ready-to-go ventilation circuit. This module's learning goals are to review the indications, contraindications, and procedures for non-invasive ventilation with the Hamilton T1. We will learn how to configure the ventilation mode for CPAP and BiPAP, set the control parameters for each mode, monitor the ventilator for patient feedback, and reveal a brief non-invasive ventilation report to the receiving facility. The indications for non-invasive ventilation are respiratory distress secondary to COPD, asthma, pneumonia, impending respiratory failure, and congestive heart failure. Non-invasive ventilation is contraindicated in apnea, hypotension with a systolic blood pressure of less than 100 millimeters of mercury, and in cases involving uncontrolled vomiting. The adult pediatric breathing circuit used for mechanical ventilation is the same as non-invasive ventilation with CPAP and BiPAP. To prepare the circuit for non-invasive ventilation, attach an inline end tidal CO2 and an adequately sized non-vented CPAP BiPAP mask between the flow sensor and the patient. The mode choice for CPAP and BiPAP is simple because both therapies use the same non-invasive mode on the T1, NIV. Touch the Modes button on the upper right corner of the ventilator screen. Then, choose the NIV ventilation mode and tap Confirm on the lower right corner of the Modes selection window. The control settings for NIV appear. Tap Confirm again to complete the mode change process. Notice that the current mode changes as shown in the upper left corner, but only after the user taps Confirm a second time. When changing ventilation modes, always select the new mode and confirm it twice, noting the change in the left upper corner before applying changes to the controls. My typical approach when setting up a particular ventilation mode is to tap the desired mode, touch Confirm twice, select controls, and then make any necessary adjustments. Although most providers will utilize bi-level support or BiPAP for added patient comfort when non-invasive ventilation is warranted, imagine your patient has pulmonary edema and oxygenation is the unilateral focus. This is a potential case for effectively utilizing CPAP. Select modes, NIV, Confirm, notice that the mode did not change to NIV. Tap Confirm again, now we are in NIV. and controls to enter patient-specific settings. CPAP offers continuous flow during inspiration and expiration and positive end expiratory pressure, but does not offer inspiratory pressure. Therefore, turn the delta P support or inspiratory pressure down to 0 to properly set up the control parameters for CPAP. Since the patient has pulmonary edema and the issue is oxygenation, bring the PEEP up to 10 and set the FiO2 to 100%. If oxygenation does not improve with the FiO2 at 100%, increase the PEEP by 2 centimeters of water with a maximum PEEP of 15. Remember, pulse oximetry takes at least 45 seconds to 1 minute to reflect current physiology, so be patient, observe your patient, and gradually modify the positive end expiratory pressure. BiPAP, bi-level positive airway pressure, plays a crucial role in helping eliminate carbon dioxide from the body. The inspiratory positive airway pressure, known as IPAP, helps increase tidal volume, enhance alveolar ventilation, reduce the work of breathing, and correct hypoventilation. Many patients are more comfortable on BiPAP than CPAP. How does BiPAP improve tidal volume? During inspiration, the inspiratory pressure assists the patient by increasing the volume the patient inhales with each breath. By taking more gas into the lungs, the inspiratory positive airway pressure ensures that more CO2 is eliminated during exhalation. Carbon dioxide is eliminated during the exchange of gases between the alveoli and blood. Adding inspiratory pressure increases the tidal volume and enhances alveolar ventilation, which allows for more efficient removal of CO2 from the blood. Inspiratory positive airway pressure minimizes the patient's breathing work by providing pressure support during inspiration. This reduction in breathing work helps the respiratory muscles function more effectively, contributing to better ventilation and CO2 elimination. The patient who is anxious and labored will consume more oxygen and consequently make more CO2. In hypercapnic respiratory failure, the inspiratory positive airway pressure helps to correct the elevated carbon dioxide and improve ventilation overall. If your patient has adequate spontaneous respiratory effort, BiPAP will increase the air reaching the alveoli with each breath, thereby improving CO2 elimination. Select modes, NIV, confirm, tap confirm again, and now we are in NIV, and then select controls to enter patient-specific settings. Remember, in Module 6 of Mechanical Ventilation Basics, we learned that the Hamilton T1 is an additive ventilator. Any pressure we set for delta P support is added to the PEEP to make the peak inspiratory pressure. For example, if the PEEP is 5 and I enter a delta P support of 10, the patient gets 15 of inspiratory positive airway pressure because 5 of PEEP plus 10 of inspiratory pressure equals 15. I will know I set the inspiratory pressure correctly when monitoring ventilation parameters because the P peak will reflect the inspiratory pressure of 15 centimeters of water. Let's set up BiPAP for a patient with emphysema. The patient is Wheezy McGee. Wheezy is in a tripod position, breathing 32 times a minute with accessory muscle use and having 2 to 3 word dyspnea before becoming winded. His blood pressure is 160 over 100, oxygen saturation hovers around 89%, and his end-tidal CO2 is 68 millimeters of mercury. For a patient who has hypoxemia and elevated carbon dioxide, bi-level pressure support is idyllic. First, enter the oxygenation controls. I'll begin with the FiO2 set to 100% and the CPAP set to 5. To follow the mechanical ventilation policy for this patient with hypoxia and hypercapnia, I'll set the delta P support to an initial setting of 5. How much inspiratory pressure will the ventilator deliver with a PEEP of 5 and a delta P support of 5? The answer is 10 because the Hamilton T1 is an additive ventilator and 5 plus 5 equals 10. You'll monitor the patient's physiology carefully. If the CO2 remains elevated, consider increasing the delta P support in 2 centimeters of water increments for a more tolerable CO2. The maximum delta P support is 15. Of course, if oxygenation is lagging, you can make similar incremental adjustments to the PEEP and FiO2. Report to receiving. Let's say you treated Mr. McGee and are reporting to the ED team, including a respiratory therapist who is prepping their BiPAP machine. What do they need to know about your current BiPAP settings? So on the T1, let's say that you settled with a PEEP of 5, an FiO2 of 60%, and your delta P support of 5 centimeters of water remained effective at bringing the end-tidal CO2 down nicely. So here is your very basic BiPAP report. The patient is on BiPAP at 10 over 5 and 60%. Even though you entered 5 for PEEP and 5 for the delta P support, the T1 is an additive ventilator and 5 plus 5 equals 10 for the inspiratory pressure. Since the patient spontaneously breathes on non-invasive ventilation, you will notice pink triangles below the pressure waveform indicating patient breaths. Noting the patient's peak pressure, exhaled tidal volume, breath frequency, and minute volume is excellent for your charting later. A good mask seal is vital for effective CPAP and BiPAP because a leaking mask will not function well and render the therapy ineffective. On page 2 of the monitoring section, the T1 defines a percent leak measured by the flow sensor. A 0% leak is excellent, but in practice is challenging to achieve. Aim for leak percentages below 10%. However, a leak percentage less than 20 to 25 may still work to improve patient outcomes. When the leak percentage is excessive, adjust the mask, consider changing the size, or make other modifications to improve the seal. Non-invasive ventilation is not just a tool, it represents a giant leap forward in our ability to provide the best life-saving care.